Good morning. I will be introducing our next speaker. Mrs. Clyatt serves as the Maternal Health Community Outreach Coordinator at the Maternal Cardiac Program at Northeast Georgia Health System. Northeast Georgia Health System is a partner with Hope for Georgia Moms. This pilot initiative supports the use of a validated cardiovascular diseases risk screening tool to automate assessments of pregnant and postpartum women to identify high-risk patients and refer them to specialists. In partnership with NGHS and the Georgia Heart Institute, Hope seeks to extend this model beyond inpatient OB units into ambulatory OB offices, primary care offices, EDs, and urgent care. Mrs. Clyatt holds an AS in radiological technology, an AS in nursing, a BS in nursing, and an MS in nurse midwifery. Currently, she is a PhD student in nursing at Georgia State University. She is certified in nurse midwifery, electronic fetal monitoring, and RNC OB. Please help me welcome our next speaker, Mrs. Robin Clyatt.
Good morning, everyone. Glad to be here. Somebody will have to help me figure out how to get to the next. Just keep going.
Yep.
All right, so good morning. So yes, my name is Robin. I am from East Georgia Healthcare System, and I am a midwife. I celebrate 30 years as a nurse this month. Who'd have thought I'd have found a profession that I love so much, but no, I don't know what I want to be when I grow up. That's why I have so many degrees. I love school, I love research, and so when I got out of nursing school, I decided that I wanted to be a cardiac nurse. So I went to telemetry and cardiac care unit and all the places and loved every moment that I was there. And then I met a person, as we probably all have somebody in our life, who decided a fork in the road for us. And so I met a lady who told me about midwifery because I had wanted to be an OBGYN when I was growing up. And in rural South Georgia, from Thomasville, not Thomaston, Thomasville on the Florida line, that was not a dream that was attainable in the early 1980s. And so I moved away to Houston, Texas to try and make that happen, and it didn't. And this lady told me about a midwifery school, and I was like, oh, what? I can do it at my house, like in my community? She's like, yes. And I'm like, sold. So she changed the trajectory of my life, and I'm forever grateful. I served as a nurse midwife for about 10 years in South Georgia. I worked in Atlanta for just a brief period of time when I got out of school, but my heart and soul was in my hometown, and to go back and to serve the ladies in my hometown as a midwife for nearly 10 years was the highlight of my career. But like Dr. Reddick said, our patients are getting sicker and sicker and sicker. And unfortunately, I had one of my very best friends had GDM in her pregnancy, controlled, normal ultrasound, normal everything. And she came into labor, and normal progress, normal everything until it wasn't. We had a shoulder dystocia. 10 minutes on the perineum. We finally got him out. He was supposed to have weighed, according to the ultrasound, about 7.5 pounds. He was 10.5. He lived long enough to get into the ambulance to make it to Tallahassee. He almost made it to Tallahassee, and he expired on the way to the hospital. And it broke me. But it gave me, you know how we take our anger and we take our grief and we take our resolve and we put it in line and we say, I don't want this to happen to another patient. I don't want this to happen to another one of my friends. She went on to deliver 2 more beautiful baby boys, and I get to see them often. And so I got out of midwifery, but I got into education. And so I worked at Phoebe Putney for a little while as an educator. And then I got the opportunity to marry, cardiac, and maternal. And so with Hope for Georgia Moms, they really have, well, I will say, God has really organized my whole life to bring me to this point, and I am forever grateful for it. So we're going to talk a little bit about what to expect when the unexpected happens and the critical role of cardiovascular screening while we're pregnant, before we're pregnant, and in the postpartum period. That's where my heart is near and dear, is in the postpartum period. So my objectives, we're going to look at some of those maternal mortality trends that we've already looked at a little bit. I'm going to tell you a little bit about Hope for Georgia Moms and who we are. We're going to talk about how adverse pregnancy outcomes, which are all the things that we've been talking about, maternal mortality, high blood pressure, diabetes, all those things, how they affect long-term risks. And then we're going to talk a little bit about how we can use a cardiovascular screening tool and see how we can assess our patients who've had those adverse outcomes. How does that affect their long-term care? So I want to start with a story because I know we remember stories way better than we ever remember anything that I'll ever say here. And so I found this story from this beautiful woman, and I think it will grab your attention and help you understand why we're here and why cardiovascular screening is so important. So. Am I gonna, never mind, here we go. Hang on a second. Gotta love technology, right? Let's see what might end up the volume looks like. She won't let me stop her.
Do you have a technical right besides it? I don't understand this.
I tried to increase it here, but it won't let me.
Sorry.
We got our expert.
Yeah.
Yay! Gotta love it.
There it's up.
There.
Reminded me that I was complaining of not feeling myself, but I wanted to go out. It was the first time that we would be out, at least for myself, in a few months. At the time, with my medical background, although I knew the signs and symptoms of a heart attack, because I was only 31 at the time, and I had just had a baby, so I was celebrating life, I had no idea that it was a heart attack that was happening. I felt this crushing of my chest, like my chest was just in a vice, and I felt like I couldn't breathe. And then I had the numbness down my left arm, the tingling, the chest pain up through my jaw and neck, and at that point in time I knew something was terribly wrong. This picture here is a picture of my little family. It's myself, my husband, and my 3 children. I take many photos. I like to kind of take photos in order to remember, because the day of my heart attack, I took a photo of my son, and I look back at it as that possibly being the last photo that I could have ever taken. When I was pregnant, a discussion about any heart-related issues was never discussed. I had no idea about the risks afterwards. Women need to be confident and know themselves so that they can advocate for themselves. You have to be able to express what you're feeling and have enough confidence to say, no, it's okay to disagree with a doctor. The type of heart attack that I had wasn't standard. So I had to kind of make my own moves. I had to figure it out for myself. And it's because I did that I'm here today. I survived for a reason, so I'm going to take every single opportunity that I have to live.
So I love her story. I love her story of fighting for herself. I hate that she has to fight for herself because we in medicine don't do a good job of listening to our patients. They come, they complain, they say the obvious, they say what's wrong, they say, and we normalize them away. Oh, that's normal. Oh, that's part of pregnancy. Oh, that's this. Oh, it'll go away. And we normalize it. So I love her story because she is advocating for herself. And hopefully at the end of this talk, you'll be wanting more to advocate for your patients. So the U.S. maternal mortality rates, we know how they are. In 2019, they were 20 per 100,000 deaths. And then during COVID, they got worse up into the 30s. And then by the time we got to 2022, they were back around 20. I think the latest data is out now for 2023, and it's looking like we're somewhere around 18, which is improving. But we're still not where we want to be. In Georgia, our data is collected just a little different from national data. National data includes deaths up to 42 days after delivery, whereas Georgia data now includes deaths up to 1 year after delivery. And we do it in sets of 2 years at a time. So we're not really comparing apples to oranges, so don't think you can take that last odd and compare it to this one because it won't really give you an adequate view of what's happening. But in the state of Georgia, between 20 and 2022, we lost 141 moms, which is horrible, which gave us a ratio of 37.9 moms per 100,000 live births who died. And the leading cause of those deaths were cardiac related. Of those deaths, and this is the part that just shatters my whole heart, 87% of those deaths were deemed preventable. They came in contact with us, they were triaged by us, they were presented to us at a 3-week postpartum visit or an ED visit or an urgent care visit or as a friend who said, I don't feel so good. And we triaged them away, and they went on to pass, and that breaks my heart. So when do they die? So this is the timing of the deaths between 2020 and 2022. During pregnancy, we lose about 18% of the moms that we lost, 11% within that first 24 hours, and usually those are related to postpartum hemorrhage. The 1 to 6 days can also be related to postpartum hemorrhage, but look at that 43 days to 365 days. After your 6-week visit, which nobody goes to, we lost 42 moms in that time period. And the problem is nowadays, and this is what I'm studying, is there's no health structure for women in the postpartum period. There's nobody to hold their hand from I had a baby to now I'm transitioned to primary care, because if you're like me, who has 5 children and I love to stack them, and I would have people frequently say, didn't you just have a baby? Yeah, I did, like 13 months ago. And then, didn't you just have a baby? Like, yeah, 18 months ago. The baby's 18 months, and here I am again. So where do I get my care from? My obstetrician. For 9 straight years, over 5 children, the only healthcare provider I saw was my OB. And so we don't have a mechanism to help women get from OB into primary care, and we're hoping to partner with some postpartum people that will help us do that. But it's going to be so important because this is a time, and we've exposed a gap where these women are dying, and we need to do some work. So the HRSA, which I think no longer exists, I don't know what they're going to call it now, but it's probably got some other name by now. HRSA was a response from the government for maternal mortality in the United States, especially during COVID when death rates went up so high. The government got real concerned, and they started like, okay, how can we help? Let's pour some money in. And so HRSA gave grants out. As of 2019, there were 42 grants. Georgia was one of the grants that got awarded that at Northeast Georgia. That's where Hope for Georgia Moms comes in. And so our job as Hope for Georgia Moms was to develop a task force of members of all kinds of people, from doulas to psychiatry to OBGYNs to residents to family medicine, EMS. I want everybody to the table because, like we talked about just a few minutes ago, this is going to take a village to take care of these moms. Nobody can be the captain of the ship. There's no one person who's going to be able to say, yes, I can take care of all of this person, because most of the time we can't. So Hope for Georgia Moms created 5 focus categories for the state, and those 5 categories are data. We want to know what's happening, like what's really happening, so our data. One was advocacy and respectful care, and I love this section because it's teaching moms how to advocate for themselves. Don't just say okay every time somebody says, oh, well, that's nothing. No, fight for yourself. Respectful care comes from listening. Just listen. When a patient presents in front of you, close your mouth for 25 seconds and sit uncomfortably in the silence to allow them an opportunity to say, this is what's going on with me. I am an extreme introvert, just so you know. This is very hard for me. But when I would go see my providers and they would ask me a question, I'm not that person who can just blurt out an answer. It's going to take me a second. I got to sit there. I got to think about what you just said. I got to edit it about 8,000 times before it comes out of my mouth, right? And so sometimes just give me the space to say what I need to say is an act of respectful care as far as I'm concerned. Another area that we focus on is maternal mental health. If you don't know about Peace for Georgia Moms yet, I'll throw that out there as a resource. It's on the end of my slides as well, but Peace for Georgia Moms is a telehealth that's connected with Emory. It's free for providers to speak to another provider about how to care for somebody who might have a mental illness or need mental counseling, or not counseling, but need mental guidance during their pregnancy. And then finally, doulas and care access. So we're about to change the name of this. Don't tell anybody yet, but I think we're going to change the name from Care Access to Rural Health. And because I'm in Thomasville, Georgia, like how much more rural can you be other than maybe Judy from Bay Ridge? And so we're going to probably call it Rural Health. And so I'm really interested to see how we can expand our care and the ways that we deliver care in the rural sections. And so the last one is maternal cardiac, and that's my favorite. Northeast Georgia has worked very hard to create a screening tool for cardiovascular disease, and we're gonna go over that. So what is an adverse outcome of pregnancy or an adverse pregnancy outcome? You may hear somebody call this an APO at some point. It is complications that negatively affect the mom, the baby, or the newborn. And that can happen during pregnancy, birth, or during the postpartum period. It affects about 10 to 30% of pregnancies across the boards. It seems really higher than that in the South. I don't know why, but maybe that's just a national average, and there are some really healthy women someplace giving birth. If you know that place, please tell me where it is so I can pop in on them and see how normal looks. And what is this caused by? It's usually a stressor, either a metabolic stressor like gestational diabetes, or it's a cardiovascular changes or the vascular changes that are associated with pregnancy. And those complications for the mom look like hypertensive disorders of pregnancy, all the different kinds, the gestational diabetes, or even abruption. And for the baby, it can look like a preterm birth, or it can be growth restriction, or a small for gestational baby. So how do these adverse effects in the pregnancy contribute to cardiovascular disease? Well, we know that if you had a hypertensive disorder of pregnancy, you're 2 to 4 times risk higher of developing chronic hypertension now. And you're going to develop that way earlier than a counterpart who didn't have blood pressure issues while she was pregnant, by about 10 years. So if you think of hypertension and how it affects your kidneys, if you're going to have it 10 years longer than your counterparts, your kidneys are going to have to suffer, especially if you're not controlled, an additional 10 years. And so if we can identify that and manage it early, then maybe we can prevent some of those long-term issues that may occur from having hypertension. And we know that with every pregnancy, if you had a hypertensive disorder last time, the likelihood for you having a disorder at this time is also going to go up. Long-term effects, when I was looking this up, I was very interested in this vascular dementia section as a consequence of cardiovascular disease and kind of the adverse effects of pregnancy. There's a significant rise in dementia in Black ladies. I would love to go back to their histories and see if there's a correlation. Like, if you have dementia now, tell me about your pregnancies. What kind of issues did you have? And did that somehow contribute to this? And I just think it's fascinating. Not good, but it's an interesting connection between that everything that happens, even from a pregnancy, shows up later in older age. So what sets the stage for this? Like, how do we get ourselves painted into this little corner? Well, obesity in 20-year-olds plus is running about 41%. I say that our food is killing us. I tell people that all the time. Your food's killing you. Your food's killing you. I didn't have a closet with the boxes of things in my closet like she was talking about for nutrition, because that's really what we want to do. But I created a poster board that had snack bags of sugar in them. And I would take the most common things that my patients would tell me that they're eating, and for each 4 grams of sugar that was in those items, I would put a teaspoon of sugar into that little snack bag, and I'd cut out the title of whatever it is they were eating or drinking, and I would put that in every one of my exam rooms. Mountain Dew has about 19 teaspoons of sugar in it. The bottle of apple juice or orange juice in front of you today, if you take that grams of sugar and divide it by 4, that's how many teaspoons of sugar is in your diet. And then we wonder why obesity is an issue. Because I can't tell you how many patients I've had. How many glasses of water did you have today? How many? Maybe 1? Maybe? How many glasses of apple juice have you had today? Well, WIC gives me that, don't they? I can't tell you how many times I've been the one who call over to the WIC office and be like, please don't give my patients apple juice. Give them water. Give them water. Give them something healthy because we're killing them. She's already struggling with obesity. Why are we trying to make that worse? The second thing is, this was astounding to me. Women 18 and older are suffering from hypertension at a rate of 44% at 20. That's insane. But that's what our diet is doing to us. That's why I listed the obesity first, because I honestly think it's the obesity that's leading to all these other things. Physical activity, only 20% of women ages 18 or older do physical activity based on what the guidelines say. I can remember when I practiced, I can't tell you how many contraceptive visits I would have with my little middle school girls, and I'd be giving them all their list of contraception that they could choose, and they're like, oh, I don't want Depo. I'm like, but why? Oh, it's gonna make me gain weight. I don't want to gain weight. Okay, I hear that. And you're gonna go from middle school, where you have to go to PE once a week, twice a week, 3 times a week, whatever it is now. And you're going to go to high school where you're never going to have to exercise again. Guess what? Moving from exercise to no exercise is going to do to your weight. It's going to go up. So don't blame it on the Depo. That's a soft out. Like, don't do that. You're not worried about not exercising anymore, but you're okay having the potential of a pregnancy. Like, sometimes you just have to paint a picture of what life looks like, and I don't think any of us have a big picture, and we miss things, and so we need other people around us to say what those things are. So these are the things that set the stage. So these lovely people got together and decided, well, how are we going to combat cardiovascular disease? We know it's an issue. American Heart Association, that's who did the video for us earlier. CMQCC is the California Quality Initiative, who develops all of our bundles. So the AIM bundles for Georgia that say, this is how we're going to treat hypertension, this is how we're going to treat hemorrhage, this is how we're going to treat cardiovascular disease. They're the people who kind of are on the cutting edge and let us know what's the best choices for us to do, and kind of give us some algorithms and some education on how to make that happen. American College of Cardiology is now involved in all this, because they are the ones who are having to take care of these patients now that they're 40, 50, and 60 years old. They're looking back going, what was y'all doing back there? She had this since 20 and nobody's diagnosed her. I remember just a couple of weeks ago, I was at a meeting and the maternal fetal medicine lady came out, and she's like, the physician came out, and she said, I'm sorry I'm late. My very first patient had undiagnosed pulmonary hypertension. She's 23 weeks. Like, and she's 22 years old. Like, how, these people are so sick, and we're missing it sometimes. And so I'm so glad that cardiology is finally getting on board. AAFP, thank you for all the family practitioners. You are my bestest friends, because you are the people that I really want to partner with. So if you are interested in even an inkling of postpartum care after you get out of school, and you want to see if you can help up that transition from obstetrics to primary care, talk to me, because I really want to see if we can create a model that would work. Yeah, catch me. So what are we doing right in Georgia? Well, we have a maternal mortality review committee, so we go over every single death that happens in the state of Georgia. Every death that happens here gets gone through with a fine-tooth comb by people who know what they're looking for and can figure out What are we doing? What did we miss? How can we do it? Telehealth services are available. They're not always funded and paid for, but they are available. Especially psych. We now have great psych stuff. Again, like she said last time, COVID really opened the door for telehealth services. In the state of Georgia, as of 2022, Medicaid did extend funding to cover us postpartum up to 12 months. Some of the models that are coming out, if there's midwives in the room, oh, yay! Two of us. Group centering pregnancy is a huge thing that we learned way back in the day in midwifery school, where you do group prenatal care and you put everybody together. And you have a cohesive group that learns from each other, and they learn that they're not alone, and it's a great way to deliver care. And they can share rides to come to their appointment. It solves a lot of barrier issues. Community health workers are also available, so we've got lots of doulas happening now. We've got lots of home visiting programs that are starting up and that are having money poured into them, which is what's necessary because you can't do anything without a buck, right? And then we have the Alliance for Innovation, which is our AIM bundles that focus on the cardiovascular diseases. So, and we're screening. So I created this little acronym to help you kind of hopefully remember what SCREEN stands for. So sit and listen. 25 seconds of awkward silence to let your patient say what she needs to say, or her partner, or whomever she brings as a support person to say what they need to say. Sit and listen. The next thing we're going to do is calculate a score, and we'll do that in a second. Review her history. If you had previous problems with blood pressures in a pregnancy, you're probably going to have them again. If you had diabetes before, you're probably going to have it again. So let's look back and see what we're bringing with us. Engage others, and this is that big, nobody is the captain of the ship. Engage all the people that you need in order to take care of this lady, and then educate them, because we can't do it if we don't know what we're doing and why we're doing it. And then never let your guard down. Never assume it's normal. If she's coming to you and she's complaining of shortness of breath and swelling up to her knees, and she can't breathe, and she's sleeping on 4 pillows and she's struggling, not normal. Listen to her. Never let your guard down. And ask the right question. Have you been pregnant, or have you had a baby in the last year? This one question alone will change the trajectory of your diagnosis, your differentials, because you'll look at her in a different way. You won't just assume that her shortness of breath is related to new onset asthma. It could be CHF. The other part of asking the question, and I think it's important for us to remember, our brain does not want to see a 22-year-old sick. Like, it's hard for us to reconcile that in our head. So we had a patient a few months ago, full-blown CHF. Full-blown CHF. She was 23. Do you know how hard it is to look at a 23-year-old who's this big, who had a baby 3 weeks ago? She can't breathe. She's swollen. She's got a BMP of 900 or 1,000. It just doesn't make sense in our brains. It's a 65-year-old who's got those same symptoms. I'm like, yep, CHF. The 23-year-old, I'm like, maybe it's a fluid shift. Yeah. You know, she's just third spacing. She had an epidural. They bolused her 1,000 times. Yeah. No. We have to get rid of all those. And I hate to use the word, but I don't know of another word to use. It's a bias. It's a bias for normal. We want it to be normal. We want it to be normal so bad, but it's not. So this is a busy slide. I don't care that you see it. I don't care that you can read it. I just wanted you to know, CMQCC, this is the California Quality Initiative. This is one of the algorithms that they created that's been verified and tested to know how to check people for cardiovascular disease in pregnancy and postpartum. Northeast Georgia took that algorithm and made something that's a little easier to look at. So you have two of these on your table. One we're going to use because I want you to write on it, because we're going to do some case studies and I want you to kind of see where people fall in. And then the other one I want you to take back with you and consider old-fashioned paper assessments. For the new people in the room who don't know what a manual paper, going back to manual mode is, that's when you have to write on a real sheet of paper. We don't get to click, click, click. This has been adapted to fit into Epic so far at Northeast Georgia. So if you are Epic users and you need to know the secrets to how this to get into your Epic system, don't try to reinvent the wheel. Some people have already done that for you. So I want to just give you a second to read over some of the questions that it's asking, and I'll just highlight a couple of them. Is she short of breath with activity? Does she have a persistent cough? Is her heart rate more than 110? Is she African American? Was her pre-pregnancy BMI 35 or more? Who's my OB providers in the room? Like actual clinical providers? Yeah, okay. So how many of these people are your people every day? Every day. Like my MFM, she's like, we just pre-check all these because all my patients have all these problems, usually right here. So, and then the red flags would be she's short of breath at rest. Like I'm not even doing anything and I'm short of breath. I'm having to sleep on 4 pillows at night because I can't get my breath and I can't lay down, or I'm having to sleep in a recliner. Her vital signs are way more elevated, like her heart rate's over 120, her blood pressure is up. And then on a physical exam, does she have abnormal breath sounds in the bases, and or does she have a very loud murmur? So it's not uncommon for pregnant women to have a murmur, but a very loud one, like as soon as you put the stethoscope on, you can hear it. So that's kind of the screening tool. And then so what makes it positive? To make it positive, you're going to have one in each of the blue categories, one in the top one in the middle one in the bottom one, or 4 in any combination in the blue section. If you have a positive red flag, a yes in any one of the red flag things, it's automatically a positive screen. And if you have anything on the physical exam, whether rails or the murmur, that's also a positive screen. So it doesn't take much to get you a positive screen. And so we're gonna use this in just a second to kind of go through a case study. But first I want you to hear from this maternal fetal medicine. Maybe she'll be loud.
My name's Laura Riley. I've been a maternal fetal medicine specialist or high-risk obstetrician for about almost 30 years now. Many Black women will say to me is that I know when I go into the hospital that I'm gonna have to speak up more because people don't listen to Black people. And you gotta acknowledge it. It's true, and it happens all the time across the country. I think it's worth, saying I understand. I think it's important to validate what those concerns are, whatever they are. Pregnancy is anxiety provoking, and so it's important for people to understand it's okay to be nervous, but bring your concerns forward and I will try and answer your questions so that you're not nervous and so that you can actually enjoy your pregnancy. I feel like you have to be intentional, and listening and absorbing the information and then being able to feed it back to a patient is so incredibly critical to what we do that it's worth those extra minutes. Hear her, it could save a life.
So I love how, this is CDC, so I love how it's important that all these big entities are, all these big entities are grouping together and saying, listen, 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 listen. It's the loudest plea I hear from all the organizations. Listen to your patients. We get so busy and there's 28 people on our schedule and you've got 15-minute slots. I get it. 15 if you're lucky. I've worked where I've had 10 minutes per slot and they're trying to get you to see 32 patients a day. I get it. There's no time to listen, but if we don't, there are bad ramifications for that. So please, please, please listen. So let's do a case study. So this is going to be a patient who's admitted to labor and delivery for a preeclampsia workup. She's was admitted to the antepartum unit for a 24-hour urine and for preeclampsia, and these are her initial blood pressures and vital signs. So right out of the gate, you can see that her blood pressure is abnormal, and because of preeclampsia, she's going to get treated for that. And I'm not going to go into the management of it. I only want to talk about the cardiovascular parts of this. She has 2+ edema, but her lungs are clear. So we're not to the red flag yet, but we're pushing, well, we're to the red flag because we have the blood pressure issue, but we're not to the physical signs yet with the rales in her lungs. So postpartum day 2, she has a little baby. He's delivered due to preeclampsia. And so the mom was sent home with a new order for labetalol, 200 milligrams by mouth twice a day. Her blood pressures were stable when she left, but after she got home, she's having to sleep on 4 pillows. Okay, so what it didn't say in the beginning, she's an African American woman, so she got a risk already right out of the gate. What it also didn't say is she has a BMI, that pre-pregnancy BMI greater than 35, so she got 2 risk factors just walking in the door. She didn't have to say or do anything else, just walking in the door. She's got 2 of the 4 risk factors that I need. And now you're telling me she's sleeping on pillows to try and breathe. So she goes to the urgent care because she's complaining of fatigue at 10 days postpartum. So what's the typical reasoning?
How old is she?
How old is she? We'll give her a good age. We'll say she's 26.
So they're just gonna say she's tired because she has a baby.
Yeah. She's tired because she had a baby. That's why she's fatigued. She's just exhausted. And what's some of the questions that we're going to ask her? As soon as she says fatigue, how are you sleeping? Yeah, how are you sleeping? Are you sleeping when the baby sleeps? Like it's her fault that she's not sleeping. And if you pick the wrong time to go to sleep, that's on you. Like, other things that we would say to her, like, oh, you have to sleep when the baby sleeps. You have to prioritize going to bed. You have to get somebody to come watch the baby for you a little while. What if she don't have those resources available to her? So they chalk it up to this is normal pregnancy tiredness, and the shortness of breath on exertion. They listen to her lungs. She's got some rales now in her lungs, and they do a chest x-ray and it shows some abnormalities, and so they say she has a respiratory infection and send her home on an antibiotic. Okay, can we do some blood work? Like, can we confirm any of that? So she goes back. They say follow up with your OB. So she follows up with the OB. She's got persistent symptoms. It's still not getting any better. I'm still short of breath on exertion. I'm still exhausted. The OB looks at her, says, oh, well, then let's change your antibiotics. Maybe that one won't work, so we'll switch your antibiotics. And now we'll give you an inhaler because maybe you have new onset asthma. Well, new onset asthma in an adult is rare. We don't get that very often. And so probably not new onset asthma. So you can see how she's kind of chalking up the list of starting to grow of her cardiovascular issues that she's experienced. So then she goes home and there's a 911 call. The EMS gets there. She's sat 91% on room air. She's found by her husband with extreme shortness of breath, and they transport her to the nearest ED, where she finally gets seen and somebody hears her. So when you have a red flag, you have to treat that right out of the gate. There's no time to be deciding, well, this blood pressure could be from blah, 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 blah. No, let's treat it, please. If her O2 sat is down, let's treat her, please. Notify the OB doctor. And this is where, I do a lot of education in emergency departments, and emergency departments don't have time to call the OB for every little thing, and the OB don't really want to be called about every little thing. And so there's this, should I call? Should I not call? Is it appropriate? Is it not? If she's been pregnant in the last year and she's complaining of shortness of breath, please call the OB on call, because it could be a cardiovascular issue for her. Notify that provider. The OB provider may not be able to do anything, especially if you're in a rural area where you don't have MFM close by. You may need to be making a phone call to MFM at some point. If you have a rapid response team for those red flags, you may have to initiate that. Some hospitals have those. Some of my smaller rural hospitals still don't have rapid response teams. So if you have those, be thankful. And then consult cardiology or maternal fetal medicine to get through that initial red flag area. If you have a positive screen and you've gotten her stabilized, so you don't have to make all this decisions in the moment where you're trying to get her O2 sat up or get her blood pressure back to normal. But once you get her stabilized, then make a phone call to OB, and then consider doing an NT pro BNP. The reason we do that is because it can tell us if she's in CHF pretty quickly. Normal is less than 300, and for most patients, I would say, who are postpartum, who truly are in CHF, you're going to see this number it ain't going to be oh, she's on the borderline, it's a 350, so maybe, no, it ain't going to be that way. It's going to be extremely high numbers. And then consider doing an EKG to see if there are ST changes, and usually the T wave will be inverted if there's a cardiovascular issue associated with what's going on with her. So what do I want you to walk away with from this? And I'm going to get you caught up so you don't have to worry about lunch. What do I want you to walk away from this with? Anybody can screen. Anybody can screen. My doulas can take this to their places where they're seeing their moms. You can screen. EMS, you can screen. OB, you can screen. Postpartum women, postpartum nurses, labor and delivery nurses, you can screen. Family medicine, you can screen. Everybody can be a part of this, and we can all work together to identify these ladies, get them treated, and then we can start the process of educating these moms to know this is a process that's happening to you. You didn't choose it. You can't fix it. You didn't do anything to cause this. But there are ways that we can help you navigate this throughout the rest of your life so that we can negate some of the adverse outcomes that can be related to cardiovascular health in moms. And so my plea for you and my charge for you today is, if you know anybody who's pregnant, or you visit them, or you see them, whether professionally or as a friend, and they're complaining of shortness of breath or swelling, or they don't feel good, screen them. And then send them to their providers and give them a language that says, something's wrong with me. Don't send me home. I'm not going home. I need somebody to listen to me and treat me, because something may be wrong with my heart. And so at that, I'll say thank you for the opportunity to speak with you guys today. I hope y'all are going to have a good lunch. Are there any questions about the screening tool, how it's used? She's coming.
Thank you. Dr. Elliott McLean, I'm family medicine. So I guess the question I would have is, what, given your kind of experiencing uniqueness, I'm also a South Georgia kid, what do you recommend for helping get patients to take this serious and listen to their providers? Because kind of two things that I hear coming from somebody who works outpatient, who worked urgent care, who has these moms come in, and they still end up in the ER despite that I ordered all the right stuff, sent all the right referrals,
Yeah.
or she, because I was listening to the patient before her, couldn't wait because of childcare or work commitments, or just she has a habit of being late, not wanting to wait, and leaving.
Right.
So that's the more kind of typical patient I see with this. It's not that, I mean, it feels like a lot of putting on us is, oh, you're not listening to them. Oh, you're not, I'm doing all this. And they're still ending up in the ER. So I need to figure out how to close the gap from the community level at, the people they trust, their Facebook people.
Right.
Who they trust, how to get them to say, hey, not only do I need to take it serious and expect my healthcare provider to take it serious, but I need to take it serious and wait long enough to be heard.
Right.
Because I mean, that's like when I'm staying and waiting and listening to this patient, and Dr. Collins can vouch for me because I'm notorious for this, is listening to this patient, well, we've got other patients waiting and,
Yes.
For this.
Yes.
So I guess is what else from this kind of policy level? I have a background in public health, I have a background on the Ron McDonald House, I've done all this stuff. What else from the public health, from the community level is being done or can be done to help get patients to bridge that divide so that we can help them and they take what we're ordering serious and actually go get that echo that I ordered 2 months ago?
Right. And that was also, thank you for that question. It's a great question. I think from my own personal experience, I had those exact same patients. I've spent 45 minutes or an hour in a room with you trying to help you understand, yes, this is important. Yes, this is a necessary test. Yes, this is a necessary medicine. And then they go to the pharmacy and it costs $4 and they're not willing to get it. Or the echo is going to be 3 weeks and it's not on a day that I want to do it, so I'm not going to go. Or I don't have transport and I can't go. There's so many barriers, so many barriers. And I don't think we have a good handle on mom's perspective. I mean, we're doing all we can do. But there's a lot of life happening on the other side when they get in that car or get on that bus or they go home that's happening to them that I don't think we have a clue about what's happening. And I don't know that it becomes a medical problem because we're trying to treat them. We want the best for them and we are listening and we're doing all the things. But for some reason, they just can't make that happen. And so, and I think that's why postpartum care has not done well in general. Less than half of the people show back up for their postpartum visits because there is a divide between, yes, I know this is what you told me, and I agree, yeah, kinda. I'm gonna agree in front of you. I'm gonna agree, and I'm gonna say, yes, I'm gonna do all the things. And so we go through the effort of making all that happen, and then they leave and go get in the car or get on the bus or get on whatever, and something massive happens between those two things. I don't know the answer. I don't know the answer. I wish I did.
I just feel like that's a problem that needs to be addressed too, because I keep hearing that's bad doctors, that's bad doctors.
Yeah.
What?
Yeah. No, because there are some really, really good ones.
Yeah, I think doulas are the answer again. I can't tell you how many cars I've sat in a parking lot with kids, or how many moms I had give birth accidentally at home and couldn't go in to even be seen because they had nobody to keep their 3 kids under 3. Dad was deployed. She's not a bad mom. She's not neglecting what you're saying. She's not trusting her Facebook friends, but her back is against the law. Where does she send those other 3 kids when she needs to go in to have that essential testing?
Yeah.
That's why community partners and doulas are so important. We fill those gaps. We create those opportunities for that mom with those small children to be able to go get the testing and do what you need her to do. But you have to recognize it's not always what it looks like.
Yeah.
It's not always that she doesn't trust you. Her back is literally against the wall.
I think when you're talking to mom providers, we understand that.
Mhm.
We not be surprised what we have been through.
Yeah.
And what we have experienced and what
Yeah.
we know. So again, it's that gap is how do we as a state
Right.
Not think, how do we make this a state issue?
Right.
And address it as a state?
Right.
Because I had to do it during my pregnancy. I
Right.
had all that.
Yeah.
But yes, how do you bridge that gap to address those issues that gets it there? 'Cause I mean, like I said, it kind of keeps going back, because I hear, we get here all the time. Oh, I told the doctor, doctor can't say anything, doctor can't tell whether they actually said anything or not.
Yeah.
But then we didn't listen, okay, well, I'm happy to listen to you, I need you to listen to me, and we need to figure out how to solve these problems, but I need more, like she's saying, we need a team.
Yes.
And doulas, are part of that team.
Yes. Teamwork. In the back.
Yes.
Hi.
I have a question that is related to this,
Okay.
but a little bit unrelated to what we're already discussing.
Okay.
If a mother had a previous pregnancy and about 3 years ago, and they had the screening, they had the whole thing. They had to go to a cardiologist, and they avoided heart failure, and was put on some medications and everything like that. If they are now pregnant, and I think everybody kind of knows in here, when you first get pregnant, they don't like to see you the next day after you pee on the stick, right?
Yes.
They say you have to wait a few weeks, but if you already know you have high risk from your previous pregnancy, what should they do? What should they do in the waiting time of the 3 or 4 weeks prior to their first initial prenatal appointment? And should they start consulting their cardiologist ahead of time, especially if that patient is considering another OB?
I would say, as a patient, that I would highly recommend planned pregnancies. Try not to do it like the rest of us do and just accidentally get pregnant. So try to do a planned pregnancy so that you're talking to cardiology ahead of time. You're going for preconception meetings so that you can have that.
That person was me,
Okay.
and it was not planned.
Okay.
And I am a health professional, so
Okay.
I am aware that I need to see
Yes.
somebody.
Yes.
Literally, my
Yeah.
husband tracked me. I don't know how this happened to me. So I am just,
That's hilarious.
I'm just trying to make plans now.
Yes.
Now that I know, but I just don't know who to see, because I don't know, because you have to have a referral to go to a specialist. Well, like the way I've been calling, but maybe I don't. I don't. Can you talk to me at lunch?
Yeah, right. Yeah, I would say, as a person, like, I don't take no easily. So if I were to call an OB's office and I know I was a high risk pregnancy before and I'm like have some issues that I want addressed, and they say, oh, I'm sorry, you have to wait until your X number of weeks to get in here, I'd be like, no, I'm high risk. And I need to go to the top of the line. I would advocate for myself and really push hard. And that may or may not work, but that's just my personality to do that, to push hard. Somebody has the mic. Yeah.
Hello, Robin. I have a question. Well, it's not really a question. I guess it's a comment, because I'm also a doula, and we get pulled in so many different directions because we have to be the mental health counselor, postpartum, child educator, dishwasher, whatever, to kind of bridge that gap. And I think it's just going to take all of us to continue to just keep pressing on, because we know with different agencies facing budget cuts and hospitals under different constraints, physicians under different constraints, nurses or whatever, but we just have to, as a group, just continue to press forward and continue to educate the community to let them know those pre-underlying conditions prior to getting pregnant. And I think once we get that education out there to let them know what they're up against prior to getting pregnant, then it might make a difference in when they do get pregnant and see those different complications.
Very, very well said. We are a team, and we're all on the same team that we're trying to make this happen for. The mic is making its way around.
I enjoyed your lecture. It was awesome. So my question is really related to, through the work that you guys are doing and the use of the bundling and the algorithms and the research, has it changed the thought on the appropriate method of delivery for patients experiencing a significant cardiovascular event, whether vaginal or a cesarean? I know in a lot of cases, it's always going to be a case by case, but has it changed the thought on method of delivery? So we can step in the gap with our patients and help prepare them as best we can, should that plan fall outside of what their expectations were.
So I'm not an expert in that area. I'm a nurse midwife, so I'm not an expert in that, so I'll defer to the room. Or I would say that would probably be a conversation that you need to have with the MFM and the patient so that you guys individualize that person's care. I don't think we can put everybody in a box and say, you deliver at this time, you deliver at that time. So I would say defer to your MFM to decide when that would be most appropriate based on their cardiovascular. She keeps disappearing with me. Okay.
Good morning, everybody. And, I'm going to sort of put a shameless plug in here, but I'm also going to add to what Robin was talking about. So Dr. Reddick also mentioned it in her lecture. You live in the state of Georgia, or most of you, I'm assuming. You have the Perinatal Health Partnership Program that's in place here through TPH, which is a home visiting program put in place in the last year and a half by RNs to the home, and we are getting that up and rolling, and you are funding it because the government, our legislature and governor just put a total of $9 million in the budget for it. We're opening to 75 counties next week around rural Georgia. So I need all of your help and all of your referrals to our program. This patient that Robin just talked about, this postpartum patient, is the perfect patient for us. We see anybody with any high-risk needs, whether it be hypertension, diabetes, previous hypertension, previous social determinants, problems like that, anxieties, depressions, postpartum depressions, all of them. They get home visiting for free, whether they are privately insured or whether they're on public assistance Medicaid insurance. This would be the perfect patient for what Robin was just talking about, and for what almost all of us are talking about right here. And we work in conjunction with the team. So everybody, please remember the program. Let's get it going. Let's get it rolling.
It feels like we're all just links in a chain, you know? We're just little links in a chain and we're all connected one next to another.
Your contact
Yeah.
information, we'll mail that out to this group, so everybody will have that information, so
Yeah.
we'll connect, and so then everybody will have that information.
That'd be great, yes. And please email me. I have my phone number and my text. Anything you got, send it.
One last question, Dr. Houston. And then we gotta move on.
Yes, I know it's lunchtime.
Thank you. Justin Peters, I'm OBGYN in Coffee County. So we're in a very rural area. One of the health deserts that we don't have near me. So we looked at the questionnaire that you had brought up, and looked at it in our hospital about implementing it, and we've looked at some of the resources. So my question comes that our concern with it was that the majority of our patients would screen positive for that.
Correct.
We have a very high-risk patient population. Most of our patients are obese, most of them are hypertensive. We don't have any of them within 3 hours from us. Our concern was that with most of our patients screening positive, they are going to need a referral to a cardiologist. We also have cardiology shortages, and our concern is that if we screen positive, we can't get them into a cardiologist, something happens in the meantime, is there going to be lawsuits coming back on us because we can't get them in. So there was a lot of hesitations from different departments, from different OBs. So I guess my question is, how would you direct that? Because, me personally, at the time that we had this, I had a patient with Marfan's that had an extremely high risk of aortic dissection, and I was a month and a half out before I could get an echo. Get them into somebody, and I'm calling, trying to get them in, but realistically, we have struggles getting them into a cardiologist. So how as a state can we address that and the concerns from OBGYNs of getting them in?
Whew. Well, there's not near enough MFMs in this state, one per region. In the South, in Albany region, I have one MFM, bless her heart. She's working 7 days a week, 24 hours a day. And she also had that same conversation with me. She said, Robin, I would love to screen, but why should I? All of my patients are positive. Every one of them are positive. I worked as a nurse midwife for a long time, nurse midwifery. We were taught to be taking care of patients who are normal, and I learned how to take care of patients who are not. And so my critical skills and my critical level of care of those patients had to advance just because I was in rural South Georgia. And who else are they going to go see? But if we don't screen, that's kind of like sticking our head in the sand and saying, well, if I don't see it, maybe it won't really bite me. But for the person that you find the Marfans that needs the echo, that's important for her. And I know that's an issue.
Yeah, I mean, I think that, our standpoint on it was that as physicians, a lot of times we can recognize those things.
Correct.
And that we have to look at our patient population and stratify, who is extremely high risk, who needs to get in sooner.
Yes.
Because at the end of the day, we have health limitations, we have resource limitations that we have to do.
Correct.
So, our standpoint on it, or whenever we looked at it, we're like, well, can we make this a little bit more stringent as far as criteria? Because I think a lot of this, if you're in Atlanta and you have, a cardiologist on every street corner, then it's very easy to get in.
Yes.
Somewhere where we are significant distance away from, cardiologists, significant distance away from the MFM. That was my concern with the screening questionnaire, was that I almost feel like everybody's going to screen positive.
Correct.
And it was almost that we were capturing too many patients. So, that's a very good thing. We all definitely want to get patients that need to be seen in. But that was one feedback that we had whenever we looked at it.
Yeah, and I would say that, and this is not the be all and the end all. Don't hear me say that. This is not the be all and end all. Each level of community hospital where you're working, I think, needs to adjust what you can do. I don't expect my level 1 hospital to take care of a baby the same way I would my level 3 hospital. They have to adjust, and they do have to weed it out. And I think you're right. You may have to tighten the parameters a little bit and say, yes, I'm going to screen them, but these are the only people who are going to get to move to the next level. And that's a conversation probably with your MFM, again, to make sure that you're not overwhelming them or cardiology as well.
So my name is Dr. Callens, and I think I can help to answer your question. How many people in the room are familiar with the Medical Association of Georgia? Okay, perfect. So they have started a collaborative with a lot of our medical institutions across the state to develop exactly what you're looking for. So they're piloting it right now. It is an app that will be available to providers where you can put in the information about the patient that you need help with, and they will connect you to a cardiologist. If you need to help with screening, or if there needs to be transportation to another facility, that is being piloted right now. So what you're looking for, or what we all need, is in process. And so what I will do is I will share that information with Joan so that we can get some more info about that. They've been talking to Atrium, North Georgia, a lot of the medical institutions, and so that is going to help us with that network. So we really don't want to change the criteria. We need to figure out how to get our patients what they need. Similarly, with like depression, we have the same issue. Like if you ask and they tell you, then what do you do? And that's where Hope for Georgia Moms comes in. Peace for Moms, sorry.
Peace for Moms.
But Hope for Georgia Moms too. But
Yes.
Peace for Moms solves that issue.
That's right.
No matter what corner of Georgia you're in,
right.
you can call them, and within 30 minutes, one of 2 psychiatrists will call you back with a plan, and they will email you a copy of that so you can put it in the chart.
Yes.
So regardless if you're if they're incarcerated, if they're in a rural community, whatever it is. So I will work on getting that information to you. The last part I will mention is, for example, Liberty Regional, we have a program, Mom's Heart Matters. We have a cardiologist that we work with. We have a standing appointment every week, 2 slots. So if we see a patient that is hypertensive, we know that they can get in within about 2 to 3 weeks, so we have that set up. The last point I'll make, at the very least, what we need to do, every single home needs to have a blood pressure cuff. So we have made some changes to the DCH profile to allow us to be able to prescribe that. The codes are being put in for us to be able to charge for remote monitoring, but every single patient needs to have a blood pressure cuff in their home so that we can also have the extension for what we need to do in terms of looking at those blood pressures.
Building structure, we've got to build a structure